So today I'm going to discuss the two-stage approach as the preferred approach for treatment of the infected shoulder arthroplasty. Let's make a few assumptions. Well, let me make a few assumptions. Number one, that the treatment of the infected shoulder arthroplasty is an evolving area, and that the information we have today is probably better than we have ever had before. So we're moving towards a patient-specific treatment recommendations, but we are not there yet. There's a lot of factors to consider. There are host factors, the patient's age, comorbidities, the systemic manifestations, and the ability to respond immunologically to the challenge of an infection. The chronicity of the infection, the organism with respect to the virulence, other characteristics, and antibiotic sensitivity, and also structural factors. In other words, how does this affect the bones and soft tissues around the shoulder? So this represents a multifactorial equation for us to determine the optimal treatment approach. And for me, the two-stage approach is probably the safest and most reliable. The treatment goals remain the same regardless of how we treat this. We want to have reliable cultures to direct antibiotic therapy. We have to know the organism and the antibiotic sensitivity. We want to eradicate the infection and in so doing prevent systemic sepsis. And ultimately the reconstruction has to restore range of motion, strength, and function for the patients. So the two-stage approach followed what was recognized as a successful treatment approach for infected hip and knee replacements. For shoulders, the results have generally been reliable and successful in that 80 to 95% range. However, success depends in part on following a specific treatment protocol that I'd like to review. So for me, this consists of a first stage. Once we have a confirmed diagnosis of a prosthetic joint infection, removal of all implants, extensive irrigation debridement, insertion of a preformed antibiotic-impregnated cement spacer, and multiple tissue cultures at the time of the debridement. I consult with ID, frankly, because they know antibiotics far better than I will ever know them. It's usually followed by 6 weeks or more of intravenous antibiotics. We monitor the SED rate and C-reactive protein, although that is not a definitive aspect of monitoring. When they complete antibiotics, we will re-aspirate after they've been off for 2 or 3 weeks, the so-called antibiotic holiday. If that aspiration is positive, we repeat the first stage. In the vast majority of cases, it's negative, and we proceed with the second stage. The second stage consists of a carefully planned reimplantation. I use intraoperative frozen sections in all cases, and that will help me guide treatment. A positive frozen section aborts the second stage, and we proceed with the first stage repeated. There's an extensive debridement. The reconstruction options consist of either proximal humeral replacement with glenoid bone graft. I use that when there's inadequate glenoid bone to implant a glenoid component. In the past, I may have considered revision to an anatomic shoulder replacement in some cases, but right now, revision to reverse shoulder replacement when there is adequate glenoid bone stock is the treatment of choice. I think that reimplanting a anatomic total shoulder replacement is very difficult because not only of the glenoid bone loss and the ability to achieve optimal fixation, but also rotator cuff compromise. All the cultures are held for 14 days to 21 days, and in those rare situations that I've had positive intraoperative cultures after doing the reconstruction, I do repeat 6 weeks of intravenous antibiotics in consultation with the infectious disease specialist. So this is one example, a patient 78 years old, 4 years after an anatomic total shoulder replacement, did well until 2 months before, developed pain, ultrasound showed a fluid in the joint, SED rate, C-reactive protein were normal, white blood cell count peripherally was 9,500, but the aspiration grew C. acnes, a common scenario for many of us. He underwent open debridement. Intraoperative findings were consistent with infection, not only the findings but the frozen section. So we removed the implant and placed an antibiotic-impregnated cement spacer. Following 6 weeks of intravenous antibiotics, the aspiration was negative, intraoperative CNS and frozen sections were negative, and the reimplantation was successful. So we've had some experience with this. We reported our series in 2017 in the Journal of Shoulder Elbow Surgery. We had 19 patients who underwent two-stage revisions. This is primarily men. Average age was 63. They all had risk factors. 2 of the 19 had diabetes mellitus. 12 of the 19 were smokers. 48% had previous surgery. And as you would expect, 62% of these cases had the offending organism was C. acnes. So that we had primary success rate in 74% of cases with a follow-up of 39 months. That's 14 out of 19 cases. With additional surgery and in one case antibiotics, we achieved success in 18 of 19 cases, or 95%. Our complication rate was high. 26% was recurrent infection or residual infection, and we had 16% non-infectious complications related to the reconstruction and usually having to do with intraoperative fracture or compromise. The overall outcome showed a mean ASES score of 69. So the two-stage approach for me is very important in the treatment of shoulder prosthetic joint infection. However, we recognize that shoulder replacements are not the same as hip and knee replacements. The organisms are different, the bony anatomy and soft tissue is impacted differently, and therefore reconstructions have to be considered differently. There is not one way to treat the infected shoulder arthroplasty. We are certainly moving towards developing patient-specific treatment protocols. Once we do that, we can then optimize the outcomes with the least morbidity for the patients we treat. Thank you very much.